Chapter 53, Psychosocial Problems in Children and Families. There's a familial tendency of attention deficit hyperactivity disorder. There's also speculation that some neurological disorders, such as epilepsy, can also be a predisposing factor. Maternal use of drugs can also contribute to it. There must be symptoms of both inattention and impulsivity and hyperactivity. Inattention consists of carelessness, inattention to detail, difficulty attending to work or games, misplaces things are a few examples. The impulsivity and hyperactivity consist of fidgeting with hands, feet, or hair, unable to remain in their seat for extended periods, and difficulty engaging in quiet activities are a few examples. They must have these signs for at least 6 months, begin before age 12, and have taken place in at least 2 different places. Children diagnosed with ADHD should be screened for depression, anxiety, and social impairments. They often have a diagnosed learning disability. To diagnose, these behaviors must be present in 2 of the 3 areas, which include home, school, or social situations. They have a psychologic assessment to diagnose as well. There are standard questionnaires that can be used to assist with the diagnosis. The goal of therapeutic behavior is to reduce the frequency and intensity of unsocialized behaviors. Treatment intervention should be geared towards enhancing the child's capabilities and self-confidence. Working with the parents to adapt goals is needed. Medications can be used for treatment and are most effective when used with behavioral therapies. Some of them include Ritalin and Adderall. These are extended-release medications, Concerta, Ritalin LA, or Metadate ER, which is nice for once-a-day administration. The medication must work but have few side effects. The most common side effects include weight loss, difficulty sleeping, and decreased appetite. Anorexia nervosa is an eating disorder that involves the refusal to maintain normal body weight, primarily in adolescents and young adult females. The mean age of the onset is 13 3/4 of age, but it ranges from ages 10 to 25 years of age or older. It is considered to be a life-threatening disorder. They have a relentless pursuit of thinness and a distorted body image. Many times there's a component that the child has or feels that they have very high expectations placed on them from the parents. There is a huge media impact, and they have a concept of control. Clinical manifestations of anorexia is listed on your screen. The longer this disease goes on untreated, the more severe these manifestations can be. It can be deadly if it is not treated. 3 major goals include reinstitution of normal nutrition or reversal of the severe state of malnutrition, resolution of disturbed patterns of family interaction, and individual psychotherapy to correct the deficits and disorders of the psychologic functioning. A reasonable goal would be to gain about 0.5 to 1 pound a week. They must monitor cardiovascular status when introducing foods. They have a refeeding syndrome, which is cardiovascular, neurological, and hematologic complications that occur when nutritional replacement occurs too quickly. Avoid this by slowing the introduction of food and the addition of phosphorus when it's depleted. Psychotherapy includes cognitive behavioral therapy. The goal is to increase the patient's feelings of control and responsibility towards achieving recovery. They have to want to get better. Bulimia is an eating disorder in which is characterized by binge eating and then vomiting. They may have laxative abuse, self-induced vomiting, diuretic abuse, and they also can have rigorous exercise regimes. Their weight may be normal or even slightly above normal, or it can be below normal. They will have tooth erosion, esophageal damage, and other GI issues due to that excessive amount of vomiting. Psychological issues include self-deprecating thoughts, depressed mood, history of unsuccessful dieting, usually overweight in childhood, and they have very low impulse control. Therapeutic management treatment is similar to anorexia. They need to be hospitalized for hypokalemia and esophageal damage. They need cardiac monitoring due to that hypokalemia. They also need a referral for behavioral management. Obesity, 25 to 30% of children are obese, and that may even be a little bit low compared to new numbers. The impact, it definitely can be increase their type 2 diabetes. It also will increase their risk for adult obesity. They can be at risk for hypertension, hyperlipidemia, cardiovascular disease, also social isolation. They can have low self-esteem and depression. Causes are listed on the screen. They need to have a balance of energy intake and energy expenditure. Some research shows that approximately 35 to 50% of obesity has familial tendency. This can be due to genetics and environment. Birth weight does not seem to play a long-term role in obesity. Many times it's related to the environmental factors, which include poor access to low-fat foods, minimal activity, and increased snacking. Many parents use food as a reward. Many people eat when they are not hungry. It can be due from boredom or just a habit. Diagnostic evaluation includes skin fold measurements. Another is a BMI, which is calculated by you do the weight in pounds divided by height in inches times 703 divided by height in inches. BMI is the best way to assess the children. They are then plotted on growth charts. Diagnostic tests include glucose testing, lipid panel, and hepatic enzymes. Nursing considerations will include to assess with the family history. You'll assess their diet, exercise, any abnormal labs. You'll make a goal that's attainable and not overwhelming. We typically don't put a child on a diet. We do diet modifications by incorporating healthy eating habits and physical activity. Nutritionist will be consulted. Have the child participate in goals and implementation. Typically, it's consistent with My Plate guidelines. Prevention begins with education. Remember to include the parents. Evaluate and praise all improvements. You want to provide lots of encouragement. Medical therapies. There are pharmacological therapies, but they're generally not recommended in children. Surgical therapies are hazardous in children. Manifestations of substance abuse in the adolescent can include an increased antisocial behavior. They may start to miss school, poor grades or school performance. They can be aggressive or rebellious. Family relationships can suffer, and rapid change in their mood. They no longer are interested in hobbies. They can have eating and sleeping changes as well. Treatment needs to occur in a treatment center where they have individual, group, and family therapy. Appropriate support groups are encouraged as well. Relapse in the adolescent population is high. Families that remain in therapy, attend support groups for a long-term basis, have less chance of that relapse. Parents can benefit from support groups and counseling for the parents. Please see box 53.3 for characteristics of the abusive family. Child abuse includes emotional, physical, and sexual. Indicators for physical abuse includes appearance of bruises, especially in various stages of healing, bite marks, burn marks, and signs of skeletal injury. The child may not be able to express what happened regarding the issue, or there's a conflict in the story between the child and the parent. They may appear afraid of the parent. The parent may show over harsh discipline. Teens may run away from the home if abuse is happening. Indicators of neglect include inadequate weight gain for age, poor growth patterns, and failure to thrive. Many times it can be the teacher that's noticing things. This can include the kids coming to school inappropriately dressed. For example, they'll have no boots in the winter. They may not have routine health care. Sometimes they can steal food. When observing the child and parent interactions, you may notice that the parent is unaware of the child's needs. Indicators of emotional abuse include a delay in both physical and emotional development. Many times they are overly protective of others, or they are immature for their age. They can also show overly aggressive or overly compliant behaviors as well. They may display repetitive behaviors such as head banging, rocking, biting, or sucking. There's a lack of warmth between the parent and the child. These kids are high risk for suicide. Indicators of sexual abuse can include difficulty in walking or sitting, and they complain of pain with urination or in the genital area. They can have physical signs such as bruising, lacerations of the perineal areas, or have an STI. Nightmares or sleep disturbances are common. They may have a decreased appetite, sudden refusal to participate in gym class. They may use sexual language that's not appropriate for their age. They may or may not report it, even if they are directly questioned about it. The perpetrator is more likely to be a family friend or a neighbor. Abusive head trauma was formerly known as shaken baby syndrome, as a widely recognized form of physical abuse. It is often caused by vigorous shaking of the infant. A child is often held by the extremities or shoulders. It ends up with a whiplash-type injury causing intracranial and retinal bleeding. There is usually no external sign of head trauma and usually is in children less than 3 years old. It can be hard to diagnose since there are not those external symptoms. New research has indicated that if 3 major signs of head trauma occur, it is likely to be abusive head trauma. Those include retinal hemorrhage, skull fracture, altered neurological status, apnea, head or neck bruises, subdermal hematoma, and seizures. The most common trigger is severe crying, especially if a child is colicky. Munchausen syndrome by proxy is also known as fictitious disorder, that is a psychiatric disorder where people make up or have fake symptoms to gain attention. By proxy means the parent or caregiver is the one making this up. Caregivers will exaggerate or fabricate the signs and symptoms of illness in a child. That's the proxy, to gain attention or gratification. It's rare but a serious form of child abuse. Typically, the perpetrator is the mother of the child, and she has some medical background knowledge. So what happens is the mother, or whoever it is, will take the child to the doctor, the ED, etc., and tell them the child has all these symptoms that really do not exist, or if the child has some of these symptoms, they're not up to the magnitude that the mother states. The provider will now run unnecessary tests or procedures. Most common cases include the mother states the child has seizures, nausea, vomiting, and diarrhea, and altered mental status. When trying to determine if the case of Munchausen you will consider, is the child's condition consistent with the reported history? For example, if mom states the child's had nausea, vomiting, and diarrhea for 3 days, does the child show signs of dehydration? Does the diagnostic test support the symptoms? Has anyone else witnessed the symptoms? Is treatment being provided due to the caregiver's demands?